while our speakers are getting settled, I would like to make a point that Rod, yes, you made a very important point when it comes to lateral approach. It's very important to learn the anatomy of the lumbar plexus, as well as not only for the nerve location, but for the segmental arteries and vessels. When you're starting that approach, it's very important because it's not something that's typically studied or taught.
Yeah, and actually, I think the neuromonitoring's gotten a lot more sophisticated. When I first started doing lateral surgery, there actually wasn't any neuromonitoring really, and so I used a microscope. I go down, and then I actually would find the femoral nerve, and then place my retractor anterior to the femoral nerve. So it's really advanced. And again, I think it's a balance. I think it's both neuromonitoring, but also understanding the anatomy. So I think you gotta do both.
We'll open it up for questions. Please.
Allow me, you hear me? If you allow me a little comment, only not a question. In 1977-78, I was a pre-med student with Jacques at the American University of Beirut. My aunt, who knew I was passionate about neurosurgery since I was in high school, gave me a book, Contemporary Neurosurgery. At that time, it was leather book, white, and the professor, her doctor, Professor Sami, had written a whole section about peripheral nerve surgery with epinural repair, interfascicular repair, sensory fascicular repair, motor fascicular repair. So as my mentor, Wilder Penfield, used to say, everything has been written, but not everything has been read. One more comment by another great thinker, Marcus Tullius Ciceron, en français. So he used to say, in the hand, I paraphrase him, in the hands of Professor Sami, excellence is not an action, but a tradition.
Wow. Question over here.
Question to Professor Razulic. Brachial plexus is a very complicated surgery. Do you think that some robots help us in future?
This is a 21st century challenging. This is 21st century challenging story in terms of implementation of this robotics in brachial plexus and peripheral nerve surgery. As I mentioned, there are some experience which are not only on the experimental level, but there are some serious also patient operated with robotics in terms of brachial plexus repair. So that depends on the center if can afford this kind of technology and this kind of education for the surgeons.
We are seeing,
and Mark is also a peripheral nerve guy. I was surprised that he went to the endoscopy, spine surgery, but generally speaking,
we are
okay.
we are seeing robots, and particularly the cardiothoracic, that are doing rib resections for the thoracic outlet syndrome. And so there's competition from robots on other fields to do our surgery, and then of course the same Da Vinci robots for retroperitoneal tumors. We're seeing more and more.
And for let's say tumors of the lumbar sacral plexus, for example. Yeah.
Is this on? Thank you. Those are great talks. Professor Zhang, when you talked about spinal cord AVM resection, you mentioned when the MEPs drop, you have to stop. That makes sense to me. But can you describe how you approached anterior spinal artery from a dorsal point of view? Are you rotating the spinal cord, or are you going trans-cord? Specifically, I want to know, those cases were more complicated with the AVM coming from the ASA, anterior spinal artery. Are you able to take clips and close the feeders one by one and allow the en passage nature of the ACA to continue on?
Okay. I think there's a full approach to the anterior part of the AVM fed by the anterior spinal axis. In the cervical or thoracic part, if the nidus is in the middle, we can go through the posterior midline and then follow the nidus, go deep into the anterior part. If the nidus located laterally, even the big nidus, we can use, we call it anterior to the posterior nerve roots sulcus, then go through the open the pure matter, then go to the spinal cord, and along the AVM, go to the anterior part. In very rare cases, very simple cases, fed only by the anterior spinal axis, I use anterior approach, especially for the cervical part. But it's very deep because the anterior spinal axis embedded by the pure matter in the anterior surface. And you have to dissect very carefully and find the small nidus or small fissures to resect it. And in the lower lumbar segment, we can rotate the spinal cord and find the anterior spinal axis and resect it. For the complex AVM, for me, I cannot rotate the spinal cord to find multiple feeders from the anterior axis and calculate it and resect it. These are 4 approaches. Thank you.
Hi, I'm Sebastian Koga from New Orleans. A question for Professor Rasulich. Is MR neurography a standard of care? Is it becoming necessary in peripheral nerve surgery? What is your experience and recommendation?
Same answer like for the robotics. This is nowadays in high-level centers very useful tool for preoperative evaluation and then after following postoperative regeneration. But generally speaking, this is also a matter of who can afford this in these centers. If we are talking about tractography, neurography, of MRI. So this is a same story, but it's very important.
Yeah, question about endoscopy. Actually, I'm going to ask my partner, Daniel Kim, to comment. I'm going to force you to comment on what Mark has been talking about, but let me give a background. 1962, Gérard Guillot used first-time endoscopy transsphenoidally. Nobody did anything for 34 years till Joe JHO from Pittsburgh reported the modern endoscopy. Again, not much happened till 2005 when really Amin Kassam kind of popularized it. And then, of course, skull-based endoscopy took off. Are we going to have to wait that long for spinal endoscopy? I don't know if it has merits. I don't do any spine. You've done everything under the sun. Those of you who don't know, my partner, not because he's my partner, is an unbelievable surgeon who's done it all in the spine. I'd like your perspective on what Mark is kind of challenging us with.
Spinal endoscopy, if you go out, a lot of Germans in Eastern Europe and Asia, is a very common procedure. Just the US has been really not adapting this. It's not just a discectomy. If you are just doing endoscopy for discectomy, that's not part of your day-to-day care. What you're seeing is a lot of lumbar stenosis patients. If you truly look at how we do our laminectomy, hemolaminectomy, contralateral, we're removing a lot of lamina, removing a lot of facet joints. Often, there is the pathology of lumbar stenosis, if you look at every patient, is intersegmental hypertrophic ligament flavum. I mean, that's what's causing hourglass. That's causing neurogenic claudication, radiculopathy. Why are we dissecting all those paraspinal muscles? Why are we doing all the laminectomy and fastectomy and iatrogenic induced laminectomy, instability and all that? If you really look at it, it's that hypertrophic ligament flavum, interlaminar. If you decompress that, the patient neurological symptom gets better. So using endoscopy gives you a tremendous visualization and tools. It's not just how to do, microdiscectomy. If you use this for decompressive, for the stenosis, I do all my T-lifts, interbody fusions and Herc screws and all those things. I mean, I can tell you the outcome is tremendous. I was there for 2 retractor. I did my fellowship with Rick Fassler 1997, and when the tube retractor came out, and that's the way it's going to be. But if you use any tube retractor, tube is a stiff, tube. When you dock that in there, all the muscle encroach in. Just watch your tubular spine surgeon. You got pituitary around your Bobby, taking out quite a bit of muscles that blocking your view. You took out quite a bit of muscle just to get the visualization. And microscope is outside through the tube. You're bipolar, all your instruments are blocking your view. So you're really looking through that tunnel. So I can tell you, if you've ever done, I've done all the uniportal, single channel, but I use biportal now. And you're gonna see this more and more. Instead of single pore, I use biportal, and I can tell you what I can do in day out pathology. I mean, it's a phenomenal. So to assure you, the way we used to do pituitary transphenoidal, it depends upon your Canadian, US. I mean, I was there with all the microscope. Now it's transition occurred to endoscopy, and the spine you're going to hear more and more. And I think the biggest block has been is insurance coverage. And Turkey, Asia, as a cash paying patients that can go to a facility to get latest and greatest. Here, how do we get this endoscopic assisted, the spine procedure to be covered by insurance? When it was a percutaneous transforaminal, we just got the first CPT code approved. But when you do a biportal, you're truly doing hemilaminectomy. You're truly doing laminophragminotomy. You're truly doing decompression. So you can use your standard CPT codes for those, getting cases approved. So I just want to assure you that's kind of been what's been hindering. But overall, I think what you're going to see now, there is a clearly momentum is there. And I think you're going to see more and more endoscopy spine surgery getting done.
I have a question. I'm Dr. Mehan as a young neurosurgeon. You show us the good result for discectomy with endoscope. My question is, how long did you observe your patients?
Oh, how long have I been following my patients?
Yes.
Oh, yeah. The best trials are going to show you that, outcomes at 2 years. Most of my patients have been with me for quite a long time. And you do see, that they're, my current fellow loves to make the joke, they're back patients because they always come back. But generally speaking, is that I don't see any long-term differences or detriment to the surgery. Most of my patients are going to, they kind of disappear. I don't know about you, Dan. It's just that once you've treated their stenosis, they do great for quite a period of time. And I'm not hearing a whole lot of late problems, unlike fusion surgeries for similar indications, like grade 1 sponding, decompress them. They're not coming back with the same regularity as fusion patients.
How many cases you see day in, day out? You look at MRI, you got the free fragment, you got pure radicular. That could be a cervical, lumbar. Those are the patients I can tell you, if I do this procedure, open, microscopic, endoscopic, tubular, it doesn't matter. That patient's going to be extremely happy. We know that. But there are some degenerative cases, got a multi-level, foraminal, all those are different nature. But as far as for discectomy, if you pick the right patient, they're going to do very, very well. We really have to follow, 6 months, a year, or 2 year, those are kind of different bag of, comparison. But the instant gratification of those selected patients, I think we all have to agree. A lot of times you're going to know they're going to do very well and extremely well without doing all this big lengthy study that we like to say, 2-year follow-ups.
Yeah, I agree with Dr. Kim, especially his point about, I think that it's been slow, endoscopic discectomy has been slow to take on because we kind of think of it as something for a simple micro disc or a free fragment. But when most of our patients have severe stenosis and facet hypertrophy, we just don't think of it as endoscopy is going to be a way to take care of all those problems that we see at the pathology in the spine. But I think as we learn and as you get more experienced with endoscopy, you learn how you can approach it with a biportal system, and you can address those other issues, and not just a simple free fragment.
Another problem is this industry, issue. It's always money tied. I mean, when you do endoscopy, we're doing decompression. Our codes are just decompression codes. If it's not screws and rods and cages and implant involved, there's not a whole lot of industry want to support this type of procedure. I think that's another thing I have to be upfront with you guys, and that's another reason that's been slow to adapt. Just kind of like electrical car. We know it's been out there for 2-3 decades. Why wasn't this not pushed through much quicker? We're heavily tied into carbon-based petroleum and carbon-based cars. We're working just fine. And why would you want to kill that part of the economy? So I think this is where we are in the dilemma is how do we, bridge and merge and for neurosurgical point of view, I debate this with our orthopedic spine surgeon all day long. They love to do lateral or lift cages, expendable, and open up the foramina. It looks theoretically great, but I still see a lot of ridiculous symptoms because there is that bony hypertrophy facet causing foramina. There's a ligament flavis hypertrophy causing nerve compression. So-called expendable case to the indirect decompression. I hear this debate, all the time. And we know that if you decompress nerve, the patient symptom will get better on a pure radicular symptom patients.
I think Dr. Sami, you had a question?
Yes, I would like to make some comment because it is the field of peripheral nerve and the question that endoscope is a tool, as you mentioned. And therefore, we should avoid to say, I am endoscopic surgeon, I operate everything with endoscope. Please don't do that. And this terminology is always like a salesman who wants to sell something. This is not really acceptable. I was privileged to have my colleagues ENT who was really the pioneer of endoscopy in general as ENT surgeon. And he published a big, really book on endoscopy of paranasal sinus. We worked together 30 years. So I had the pleasure from beginning to learn the endoscopy in entire neurosurgery. And for endoscopy in the lumbar disc, I tried, there was nothing I have never left it to the side. I have not tried. I tried endoscopy for all neurosurgical approaches in the last 30 years or so. And I found which one is really supporting, which one is only advertisement. Please, somebody has to say it. Because when you can do with a microscope, immediately you're finished, you don't need this endoscope. And you see everything with magnification and so you fit. But once you don't see with the microscope, then it is the place of endoscope. You have to use endoscope in order to be complete and to see all the corners. And also, when you remove a tumor, you are not sure, take endoscope like a spine and look around and see if there is something left. And this is the reality of endoscopy. But to say that I am endoscopic surgeon, that means you are not neurosurgeon. And this is the reality. Somebody has said that, and please avoid that, because we are using endoscope in our 6 operating theater. Always is an endoscope there. So we can use it immediately when we need it. And we need it, and I will perhaps tomorrow show you how important endoscope is also for neurosurgery. For the lumbar disc, what we do, we never use any more hemilaminectomy or laminectomy. The skin incision is only 1 centimeter or 1.5 centimeter. We come straight to the area where we have to go under the microscope, and then we can drill, as you say, bipolar or whatever, and we can do it in short time, all the story. And I have done at least in 20 cases with endoscope, try to do, I didn't see any great differences between a small approach and doing all the job than if you take the endoscope and try to, with all pressure to finish the thing. That is what I say. To peripheral nerve, what I would recommend to all of you is we have to motivate the young people to learn peripheral nerve surgery. I have done it many years for all over the world, and I have at least in every country one pupil I have educated in peripheral nerve, and I am proud of that they are doing. But unfortunately, my dear Lucas, the number is not increasing of neurosurgeons who are working. That is, I am very unhappy about that. This is a wonderful field. You can really help a lot of patients. I enjoyed your paper, how many cases, and also Lucas. And there have been some point in peripheral nerve which we have discovered at that time. One was that the suture under pressure, I have done at least 2 doctoral theses on that topic with the experimental work. Suture under the tension is always bad. If you take a graft, you have 2 sutures, is much better than 1 suture under the tension. This is something I wish that you include in your papers, in your presentation, that people understand the fact. The other thing is, as you have mentioned, the fascicular neurolysis. When you use the fascicular neurolysis, what means you take the epineurium, which has been changed in fibrosis, you have to learn really to take the fascicle, make free from the fibrosis, which is very often the reason of functional deficit, but not the transection and neurotomesis. And this is also something that our colleagues have to learn, that they start with the peripheral nerve is learning neurolysis. Neurolysis means microneurolysis, fascicular neurolysis. And this is something, when you do that, the rest you use then graft, you can use graft. The result of the graft, as you have shown in your papers, that is excellent. I can tell you, there is no doubt about that. That was my comment, because both topic that is in my heart, I had to say. Thank you very much.
I think we have time for,
This morning, 2 cases, so.
we have time for one last question.
So I just wanted to contribute. First of all, thank you very much. It's excellent presentations. Thanks for your wisdom. I was trained by Dr. Root and Dr. Kamp in Germany. And a couple of things that I noted was that it was easier access for bariatric patients, as well as a lot of high volume of heavy smokers that had less wound issues because of, just the minimally invasive approach, as well as, just not complications. So I think those 2 things are very helpful. I think also as endoscopic spine is evolving, the cameras are getting better, irrigation, everything else is getting better. So it does have its applications, and it is to be used as a tool in your armamentarium. And it is something that's very easy to learn. There's a learning curve, and I encourage everybody, if they're interested in using that tool, to seek education and do as many cases as you can, because it's a wonderful tool. Thank you.
Good. I'd like to thank our speakers for their excellent discussion. Thank you very much.